Welcome everybody to this webinar this morning of interesting webinar about cough and asthma. We're lucky to have Dr. Imran Satia with us today to speak about this topic. Dr. Satia is an assistant professor at the Department of Medicine at the Division of Respirology at McMaster University. He's one of the world experts in regard to cough, and he is conducting a lot of research and has many publications in the field. So we're very lucky to have Dr. Satia with us today to speak about this very important topic. So thank you very much, Imran, to be with us today.
Thank you. Thank you very much for the invitation. I shall share my slides so everybody can see, and I hope everybody who's listening in can see my front slide. So first of all, thank you all very much for attending, and thank you very much, Louis-Philippe, for the very kind introduction. I'm going to talk to you today about the title that I've been given, which is chronic cough. Is it asthma or something else? And provide a bit of a practical approach. And these are my disclosures. And I have two basic things that I want to talk to you today about. First of all, is the relationship between chronic cough and asthma, and how do they really interact? So I'm going to talk 20 minutes about that, and then maybe 20 minutes to go through a real life case of how you actually can manage chronic cough, which is secondary to asthma, and what kind of investigations and tests which you can or can't do, or should or shouldn't do, and which ones might be helpful or not. So the first thing I want to just clarify is that if we think about cough and asthma as two separate domains, we all know that cough is a neuronal defensive mechanisms to protect the lung from thermal, mechanical, and chemical injury. And this is neuronally mediated by the vagus nerve, which sends signals to the brain, and it makes you cough. And we can all voluntarily cough. When we think about we want to cough, we can cough. But we can also involuntarily cough when we get exposed to some irritants and environmental things. And that's designed, as I mentioned, to protect the airways and the lungs. So the first question is, which I often ask myself, is that what do we mean by cough and asthma? How do we assess and investigate cough and asthma? And do I treat cough, the neuronal component, or do I target just the asthma pathophysiology? So when we think about cough, we often think about the prevalence of cough, the incidence of cough, the frequency of cough, and quality of life. And we also think about what are the neuronal responses when we make people inhale capsaicin, citric acid, or mannitol. So these are the kind of endpoints that we talk about in the cough world. In the asthma world, we often talk about things like variable airflow obstruction, bronchial hyperresponsiveness, inflammation, asthma control, asthma severity, and asthma exacerbations. So one of the things that I'm interested in is to really understand is that how does having cough impact or influence asthma outcomes? That's one important issue. But also the second important issue is that how does having asthma influence cough outcomes the other way? So in the first part, I'm going to talk about this pathway, and in the second part, I'm going to talk about the second pathway. And then in the last section, I'm going to talk about the treatments. So the question one is, how does cough impact or influence asthma outcomes? So this is data from the West Sweden asthma study from Jan Lertvall and the Roxana Mincheva study. And they looked at the prevalence of symptoms in a group of asthmatics, approximately 750, and controls, about 850. And when they asked patients the questions in the last 12 months of what symptoms they were getting, the top or three common symptoms were long-standing cough, about 30%, morning cough, about 40%, and sputum production, about 36%. So the first thing to understand is that cough is a significant and a common symptom in asthma. But does having cough predict anything bad? And this is from the European Community Respiratory Health Survey, which was done many years ago by the European community. And they looked at baseline cough as a predictor of remission asthma, mild asthma, persistent asthma, moderate or severe asthma. And one of the things which you will notice from here is that just having cough, it increases your odds or risk of, developing severe asthma by almost 5-fold. So this is interesting because it says that persistent cough can actually predict you developing and having a risk of having severe asthma. This is from Neil Thompson's group in Glasgow, and he showed that even in smokers and non-smokers, if you have chronic mucus hyperproduction or hypersecretion, which is mucus which is productive of phlegm on most days, then you can see that the more mild, moderate, or severe asthma you have, the more coughing you have. So here it suggests that this chronic mucus hypersecretion is associated also with sputum and asthma disease severity, mild, moderate, and severe. What about cough frequency? So this is a study that we did about 4 or 5 years ago in Manchester. And when we looked across the different GINA categories of asthma, controlled, partly controlled, uncontrolled, one of the things that you'll notice is that as you're getting more uncontrolled asthma, that your cough frequency is also increasing. So in controlled patients with asthma, the median cough frequency is only 2 to 3 coughs per hour. But as you're getting more uncontrolled, your cough frequency is going up to even as high as 10 to 15 coughs per hour, which is a lot of coughing. And importantly, this is associated also with a reduction in the FEV1. And when we did a multivariate analysis to say that does cough independently predict asthma control, this graph demonstrates that cough frequency is correlated with the asthma control questionnaire, the 6 questions. Some of you may be aware that the ACQ-7 has 5 symptom questions, 1 question on salbutamol use or beta-2 agonist use, and 1 question on FEV1. And what this shows is that in the ACQ, there's no cough question because it dropped out. It was the 6th or 7th question in the analysis by Liz Juniper and Gordon Guyot. But what this demonstrates here is that the amount that you cough on the y-axis here, the more you cough, the worse asthma control you're likely to have. However, one of the things I've put in the red lines here is that an ACQ of less than 0.75 here, this red vertical line, and this red horizontal line is 1 cough per hour. There are still a lot of people here who are coughing 2, 3 to up to 10 coughs per hour, which is much greater than healthy controls. Their asthma control questionnaire would still be considered normal. And this is because cough is not a question in the ACQ. What about if we do capsaicin cough challenges? So one of the things that I did in my PhD is I made people with asthma, mild asthma, cough using inhaled capsaicin. And I counted the coughs by doing a capsaicin cough dose response curve. And one of the things that I noticed is that the worse your asthma control on the ACQ, the whole capsaicin cough response is left shifted, meaning that their neuronal responses have become more sensitive. And the better your control, that your neuronal responses are right shifted and are less sensitive. And this was in patients who had very mild to moderate asthma. These were not people who were exacerbations. These were not people who had severe asthma. They had good lung function. So this tells me that the neuronal responses are correlated also with the asthma control. More recently, Yoshihiro Kanemitsu and Eikyo group in Japan did capsaicin cough challenges in not mild to moderate patients, but severe patients. And one of the things that they demonstrated was that those patients who had a very sensitive cough reflex, as measured by a C5 of less than 2.44, they had a much higher odds of having poor asthma control. But interestingly, also it predicted exacerbations and almost predicted admissions. So this tells you that the cough neuronal responses have some clinical meaning, and it predicts asthma control, exacerbations, admissions. And this was an important paper published in the Blue Journal. My second part is talking about the other way. What about how does the underlying asthma pathophysiology that we are all very familiar with, such as airflow obstruction, airway inflammation, how does that impact cough outcomes? So one of the first things that I looked at was the prevalence of an incidence of chronic cough in the community, in Canada particularly. And here we have the prevalence of chronic cough on the x-axis, and here are all the risk factor variables that might increase your risk. And here we see that worsening FEV1, the presence of airflow obstruction, chest pain, shortness of breath, wheezing, they all increase the prevalence of chronic cough. Asthma is also at the bottom here, that the prevalence of cough or chronic cough in asthma is almost 20%. But also the incidence is also increased of chronic cough if you have asthma. So this suggests that asthma also impacts the development of chronic cough longitudinally. And this is an important message. And in clinical practice, this is data from almost 20 years ago, and it demonstrates that in patients who come to clinic, approximately 20 to 30% of those who present with chronic cough have asthma or asthma syndromes, such as asthma, classical asthma, cough variant asthma, or even eosinophilic bronchitis here in some of these patients. If we look in the clinical trials, the large phase 3 clinical trials of chronic cough, one of the commonest conditions or comorbidities that people with chronic cough have is asthma. And it's approximately, by itself, 18%, combined with reflux is 10% or 9%. And if you can have asthma, reflux, and rhinosinusitis, about 8%. So you can have a combination of these treatments. But either way, asthma is one of the most common comorbidities associated with refractory chronic cough. If you look at asthma and cough quality of life, so the LCQ, the Leicester Cough Questionnaire, is one of the commonest tools that is used in research and also clinical practice, which measures cough-related quality of life. And the lower the score is out of 21, the lowest score is 3, the lower the score, the worse your chronic cough. And the CQLQ was developed by Richard Irwin, and the higher the score, the worse the chronic cough. And I just want to identify here and show that the people with asthma, if you look at their LCQ scores, is very similar to those people with chronic cough, is that they are quite severely impacted by chronic cough in patients with asthma, even more than, surprisingly, more than bronchiectasis, and very similar scores to COPD. So one of the things that I also wanted to assess was that, do patients with asthma, do they have a heightened or exaggerated cough response? Is that, does the airway nerves and the reflex which controls cough, is it different to healthy controls? This was an important question. So we recruited healthy controls and asthmatics, and we did a capsaicin cough dose response, as I've previously talked about. And here you can see that as you inhale more and more capsaicin, that you cough more. And this is a healthy male in black. If you look at asthmatics, and these are, the first line here is the atopic asthmatics, that the whole curve has left shifted, they've become more sensitive, they are more sensitive, and there's an upshift. But if you have non-atopic asthma, then the shift is also even more left and even much higher. And importantly, this pattern is replicated in females, except everything is more left shifted and upshifted. So interestingly, even healthy control females in the red full line here, they cough to capsaicin the same as male asthmatics who are atopic. And female non-atopics have the highest degree of neuronal responses. And this is independent of FEV1 and airway inflammation. So the next thing we wanted to do was, okay, what if we bronchoconstrict the airways? So if I bronchoconstrict the airways by approximately 20% here, oops, I just lost. If we bronchoconstrict the airways by 20% using methacholine challenge, everybody's FEV1 goes down by about 20 to 25%. But immediately after the methacholine, I gave them 1 dose of capsaicin. So I wanted to know that when you bronchoconstrict an individual's airways, what happens to neuronal responses? And what we demonstrate on the right-hand side here is that when you do that, capsaicin-evoked cough responses significantly increase by about 30 to 35% in almost everybody, except for one patient here. So this suggests that bronchoconstriction actually increases neuronal hyperresponsiveness to capsaicin. But what we then did was to understand what happens with time. When we bronchoconstricted patients, we let them, instead of giving them salbutamol and sending them home, we allowed patients to gradually improve their FEV1 over 60 minutes. On the left-hand side, you can see that the FEV1 is coming back up to baseline. And this is saline inhalation where nothing happened. And when we gave people capsaicin, evoked capsaicin immediately after the methacholine, 30 minutes afterwards, 60 minutes afterwards, as the FEV1 was improving, the capsaicin cough responses also started to improve, suggesting that there is a direct relationship between narrowing airways and your nerves becoming more sensitive. And during the methacholine challenge, during the bronchoconstriction, people were also coughing more. You can see here that they don't cough too much, but they do cough more than the saline. They're coughing, 2 to 3 coughs during that small 15 to 20 minutes post-recovery. The third part of this puzzle is that I wanted to see what happens if you induce inflammation, eosinophilic inflammation in the airways. And here we did a whole lung allergen challenge. In the red line, you can see that we made people inhale allergen, and you get the classical early asthmatic response. The FEV1 improves, and then you get the late asthmatic response. And what we did very bravely is when patients had dropped 30 to 40%, we made them inhale 1 dose of capsaicin, the ED50 dose, and then 24 hours later, when the FEV1 has improved, but now there's a huge amount of eosinophilic inflammation from 3% down to 30%, up to 30%, let's see what happens. So here you can see we replicated what we saw with methacholine challenge, that after allergen, you get bronchoconstriction in the early response and cough responses increase. But interestingly, interestingly, 24 hours later, when FEV1 has come back up to baseline, cough responses are still elevated. Cough responses are still elevated. And this suggests that the influx of eosinophils into the airways has heightened capsaicin or neuronal responses, because FEV1 has now come up to baseline. So it can't be because of the FEV1. It must be most likely because of the eosinophilic inflammation. So, and during this whole lung allergen challenge, we had patients wearing the cough monitor. So we were also able to demonstrate that when people have reduced FEV1 and improved FEV1, people also cough more, and people are coughing when they go home at night and when they wake up early in the morning. And Mark Itzko, in almost 15 years ago, has also demonstrated that when they did segmental allergen challenge, they had increased ATP after the allergen challenge. And this is important because some of you may be aware that ATP can bind to a receptor called P2X3, which can trigger coughing. And now there's new P2X3 receptor antagonists which are being developed, which are direct neuronal antagonists to try and suppress coughing. So Matthew Drake also did some very interesting data where he looked at biopsies from patients with controls, intermittent asthma or persistent asthma. And what he demonstrated was that in patients with severe asthma or uncontrolled asthma, that there's more nerves and there's more branching. And these nerve lengths and branch points were also associated with eosinophils and substance P. So this was very interesting to demonstrate that actually maybe that people with more severe asthma, they also have more nerves which are exposed. And maybe something is driving these nerves, and if the nerves are more exposed, then maybe people are coughing more. So I hope I've, in the first 20 minutes or so, explained to you that having cough is an important trait because it predicts poor control, it predicts disease severity, and the neuronal cough responses also predict exacerbations. But also, I hope you can understand that if you have increased airway inflammation and if you have acute bronchoconstriction, that this may also impact coughing. So let's go through a case in the next 20 minutes. So this is a patient of mine who is a lecturer at university, and she's having chronic cough for 5 to 6 years. And this is significantly impacting her teaching and meetings because she gets a lot of incontinence and the coughing cause headaches. She describes it as mainly a dry cough, which is an itchy sensation in the throat and a feeling of something stuck. She thinks it's mucus and phlegm building up, but it's often very small volume, which she finds it very difficult to cough up. The triggers to cough include changes in temperature, strong smells, and talking, and she denies symptoms of heartburn or indigestion and no nasal symptoms or diseases. She was diagnosed with asthma in childhood, and she always used salbutamol as and when required before exercise. And she has eczema and allergic to ragweed, house dust mite, cats, dogs, trees, pollens, and grass pollen. And she stopped smoking 20 years ago, and she has a less than 10 pack year history. Examination is normal. The family physicians already tried PPIs and also already started low dose ICS because she has a childhood diagnosis of asthma, so she started on ICS and Ventolin PRN. And the lung function FEV1 was low normal with borderline airflow obstruction, but not too bad. So the first question I wanted to ask you, but we don't have the ability to do this, is that which investigation, according to the guidelines, would you not do? Would you not do FBC or CBC, bronchodilate reversibility, pheno and methacholine challenge, or chest X-ray? So, in my opinion, based on the current evidence, I would do a CBC to check for blood eosinophils. I want to confirm asthma with reversibility or methacholine challenge. I want to make sure there's no structural disease, so I want to do a chest X-ray. So out of these, the least evidence is for pheno, although this is very contentious and debatable. So I'm going to demonstrate that there's been some studies, a meta-analysis done by Woo Jung Sung, my colleague from Korea, who showed that, does a pheno predict a diagnosis of cough variant asthma or both, or eosinophilic bronchitis? And what he demonstrated from all of these studies, which are diagnostic studies, just remember, these are trying to work out that does a high pheno predict a diagnosis. You'll notice here that the different cutoffs were used from 30 all the way to 55. And for cough variant asthma, the sensitivity can be as low as 40%, and it's in the range of 70 to 80%. It's slightly more specific, so a high pheno can be more specific for cough variant, but the sensitivity is 70 to 80. For cough variant asthma or EB, there's less studies, but again, the sensitivity drops to about 60%. And for EB, it also drops to about 70%. So because of the different cutoffs used and the different protocols used, the diagnostic sensitivity is about 60 to 70%, and the specificity is about 80% or above. But not great, but it is what it is. But because of this, when we address the question in the ERS guideline to say, should pheno be used to predict response to ICS, there were only 3 studies. 2 are retrospective chart reviews. 1 was a prospective study which showed no difference. There were different cutoffs used. The response was not assessed using any validated tools. The ICS doses and duration were highly variable. They included smokers as well. And 1 study also assessed leukotriene receptor antagonists and found no difference between high and low pheno. So because of these reasons, we reduce the evidence to very low evidence and very low certainty. And therefore, at the moment, we don't have strong evidence to suggest that a high pheno predicts the response to ICS and reduces coughing. So some people may use pheno as a diagnosis, but the response to treatment is somewhat debatable still. So what did I do for the patient? The blood eosinophil count was 250. Reversibility was 125 and 8%, borderline, not much. Methacholine challenge was 8 milligrams per mil, PC20, so mild bronchial hyperresponsiveness, but she did have a 22% fall in FEV1. Chest X-ray was normal. So when I saw her in clinic, I said, let's increase the dose, give her Symbicort instead, 1 puff twice a day, but you can go to 2 puffs and PRN if needed. So she came back to clinic and she said, my cough is not better. And once I start coughing, I can't stop coughing, and she finds it difficulty completing lectures. So I said, okay, now you're taking 2 puffs 3 times a day, she said. So she's taking 6 puffs of Symbicort, and her coughing is not better. She doesn't have wheeze, she doesn't have chest tightness. So what would I do now? Would I give them a prednisone dose? Would I try them in Montelukast? Shall I check their sputum eosinophils? Do I do a bronchoscopy, or shall I request a CT thorax? Now, all of these are decent options, and because it depends on whether you have the availability and access to sputum and bronchoscopy and CT. But because I'm in Hamilton, we have access to sputum eosinophils. So I requested a sputum eosinophil count, and her sputum eosinophils were quite high at 8%. Her neutrophils, macrophages, and lymphocytes were all okay. So based on this, I basically gave her a 2-week course of prednisone, and I added in even a cyclacinide top-up dose on top of the Symbicort. And she came back and she said her cough was better after oral prednisone, but the inhalers are making her cough, and she still has this constant urge to cough and the feeling of something stuck. And in the subsequent 12 months, she needed 4 courses of prednisone and high-dose ICS. And she's obviously very concerned that I don't want to be taking so many bursts of prednisone. I'm gaining weight, and she's worried about her osteoporosis, thinning of skin, and cataracts. So she asked me, can you tell me why I'm coughing then? If these anti-inflammatories are not working and I have high eosinophils, and what are my future options? So the first question is, what would you say to her as to what is the explanation of her symptoms? She has eosinophilic asthma. She has refractory chronic cough. She has cough variant asthma, or she has cough hypersensitivity syndrome, or does she have all of the above? In my view, I said to her, look, that she has all of the above, because she has features of asthma with methacholine positive. She has elevated blood and sputum eosinophils. Her coughing is refractory to treatment, and she has symptoms of hypersensitivity, and cough is a predominant feature of her asthma. So I would say she has all of these 4 features or traits. And based on this, I would deconstruct her case into different traits, or potentially treatable traits. So there's the smooth muscle airway component, there's the eosinophil component, there's the neuronal component, and then there's the mucus component. And I'm going to talk a bit about all of these because there's some, moderate to weak evidence for each of these. And these are the things that we have at our disposal to treat patients in clinic. So all of you will be familiar with treating the smooth muscle with bronchodilators, inhaled steroids, and even potentially long-acting muscarinic antagonists, steroids, maintenance steroids, and even potentially anti-eosinophil biologics. There's no randomized controlled trials. We're currently doing a parallel group randomized controlled trial on mepolizumab, particularly in this group of patients who have chronic cough secondary to sputum high airway eosinophil count, to see whether or not it improves cough frequency and cough quality of life. There's some brief evidence of azithromycin, and I'll go through some other neuronal options like morphine, pregabalin, gabapentin, speech therapy, or even bronchial thermoplasty. Some of you may have access to, but the evidence is weak. So Louis-Philippe, Boulet, and Adrienne Cote published just in the last year or two this meta-analysis and systematic review of how to manage chronic cough in patients with asthma and non-asthmatic eosinophilic bronchitis. And the bottom line is that what they say, and I quote, cough-specific studies in asthma are limited as this symptom is not captured independently of other symptoms in most studies of asthma. And their bottom line is considered ICS-LABA and maybe a leukotriene receptor antagonist. And the evidence for leukotriene receptor antagonist at the time was mainly from 2 or 3 studies. On the left-hand side, this is a study from Peter Despingatis showing that compared to placebo, people who were given Zafir Lucas for 2 weeks had a significant reduction in their cough scores, but placebo didn't. The Spectre study showed improvement with Montelukast, with improvements in mean change from baseline in cough scores. There was an improvement with Montelukast, but not with placebo. But there was another study which was done by Keita et al. Showing that there was no significant improvement compared with placebo, but when they combined leukotriene receptor antagonists with beta-2 agonists, it worked in only those patients with cough variant asthma. So some people think that leukotriene receptor antagonists, there may be some benefit. And this was some more recent data from 2018 showing the same message, is that if you give people ICS with a leukotriene receptor antagonist, there's some reduction in cough scores, even though there may be no improvement in FEV1 or FEV1 FVC, that this may be improving the neuronal component. But bear in mind that these cough scores were, this is an unvalidated cough measurement, and there was no placebo used in this study. It's not placebo controlled. There's been a lot of discussion about azithromycin because some of our patients describe these features of chronic bronchitis and mucus and phlegm, and they may have some airway thickening in their CT scan. So we reviewed this as part of the ERS guideline. And here I want to just demonstrate that overall, there's a bit of a reduction in cough scores in the LCQ by minus 1.27. The MID is minus 1.3. But this was predominantly from one study of Burkhoff, which was in patients with, if I remember correctly, who had chronic bronchitis and more of a COPD phenotype, that these people benefited. But there was a trend to improvement in the cough severity score as well. But there's only very few studies, only 2 or 3 studies at azithromycin. I was able to find Peter Gibson's study in the AMAZES study, which was done to check for exacerbations, which met the primary outcome of reducing exacerbations by almost 40 to 50% in severe asthma. But one of their secondary endpoints was cough before and after treatment. And this was on a visual analog scale. And there was a significant reduction, although it wasn't a huge improvement. There was a small reduction in the cough severity VAS score. And when they stratified patients based on those people who had cough and sputum on their VAS, more people with azithromycin benefited with reduced exacerbations. So there may be some signal there. And as a result of that, I occasionally give people azithromycin, making sure that, Monday, Wednesday, Friday, 250 milligrams, and I warn them about diarrhea and tinnitus and deafness. And some people have had a good response. What about tiotropium? So there's a one uncontrolled study with no placebo and no objective cough frequency showing that before and after tiotropium, there was a reduction in cough visual analog scale and an improvement in the Japanese Leicester Cough Questionnaire by approximately 2 scores, and the VAS reduced by about 20 millimeters. So this was the tiotropium evidence. Although there's no placebo, some people may benefit from tiotropium. And this is a study by Alan Marie showing that mepolizumab in patients with severe asthma reduced the 24-hour cough frequency, although this cough monitor is not a validated, or it's the Hull cough automated cough counter, and it was only in 11 patients, and it seemed to suggest that there's a downward trend. But again, I mentioned that there's no placebo here. It's not a controlled study, and we're currently doing this study of mepolizumab with a placebo with a validated VitaloJAK cough monitor over 3 months of treatment. So that's the mepolizumab. So now what would you do for our patient? You've tried everything else. She's on Symbicort high dose. She's had 4 bursts of prednisone. And I'll tell you, I already tried her on Montelukast and it didn't work. So, would you try morphine, pregabalin, gabapentin, a biologic, speech pathology, or azithromycin? In this case, at the time, I offered her low-dose morphine because in the past, Montelukast didn't help. On the HRCT scan, there was no evidence of bronchiectasis. Her neutrophil count was only 40%, which was within normal range. So I didn't feel strongly about azithromycin. We can only prescribe biologics at the moment. It's only licensed for people with severe asthma with exacerbations. So at the time, I didn't prescribe a biologic. And my preference is for low-dose morphine compared to pregabalin or gabapentin, because if it works at low doses of 5 milligrams twice a day, and the response often is very quick within the first week or 2. So I reviewed the patient, and she said that the morphine really made a big improvement. And she also was able to give her full first lecture, and the throat irritation and urge to cough sensations were also reduced, and she was tolerating the medication well and was sleeping much better as well. And she was eating lots of fruit and veg to help with constipation. But she did ask me how long I need to continue for this, because she's scared about long-term medication. And I said that, there's no evidence about duration, but many patients of mine have safely taken this medication for many, many years, with some titration to maybe once a day, or giving them some breaks when cough is well controlled. So the summary of my talk is that chronic cough is an important trait of asthma. It's important that we confirm asthma with objective evidence. It's important that we assess inflammation, mucus, and airflow obstruction, and if it's present, to treat accordingly, and to consider azithromycin only in select cases if you think they may benefit, if there's neutrophilia or there's some bronchiectasis or airway thickening. Some people may benefit from leukotriene receptor antagonists. But importantly, if there's features of cough hypersensitivity, then it's also important that we treat the neuronal component, either with pharmacology, with centrally acting modulators, and speech therapy, if it's available in your area or locality. There's new treatments currently being developed, which are peripheral antagonists called P2X3, and hopefully this will be an option for patients with refractory chronic cough secondary to asthma in the future. So I'd like to thank all of you. I'm going to stop there and leave 20 minutes or 15-20 minutes for discussion and Q&A. And these are my collaborators and funders. And if you need some more information, then you can go to this website, which is my website, chronic-cough.ca, which will give us some more information. So thank you very much. And I'm happy to take any questions and have a discussion.
Well, thank you very much, Imran, for this most interesting talk. We already have quite a few questions, so I will ask you those. So the first question is about the cough variant of asthma. There is a question about its diagnosis. How can we diagnose this entity? And in fact, I can add, do you think cough variant of asthma is a separate entity, a separate phenotype, or is this just mild asthma with an increased cough reflex?
Yeah, so this is one of the commonest questions I get when it comes to talking about asthma and cough, because when I look back in the literature, this description of cough variant asthma was initially made in the 1970s by Glauser and then McFadden, and there were 2 or 3 New England Journal papers. And it was only 7 or 14 patients, if I remember correctly. And the way they described it was that they have asthma, cough is the only symptom, no wheeze, no chest tightness, no shortness of breath. Cough is the only symptom. They have asthma, but importantly, in their case series of 7 to 14 patients, when they were given a bronchodilator, I think it was albuterol or salbutamol, one of the early beta-2 agonists, their cough disappeared. So they said the diagnosis of CVA, or cough variant asthma, was made when cough is the only symptom and they respond to bronchodilators. The problem we have is that at least 2/3 of patients don't respond to bronchodilators. So is it really cough variant asthma? So some people now call this, cough predominant asthma or something else. But the bottom line is that not everybody responds to bronchodilators. And for asthma, we would never give monotherapy with bronchodilators. We'd always give them an ICS. So that definition is somewhat out of date. But my personal view is that I think that this cough variant asthma is more of a neuronal disorder, and that there's more neuronal features of urge to cough, coughing to triggers, irritation. And that's why I think that in that population of patients with CVA, that they respond a lot better to neuromodulators rather than bronchodilators and steroids and all these other things. But this is just my opinion. And we really need to do some studies looking at recruiting patients with cough variant asthma, and classical asthma, and then giving them the treatments and seeing who respond best to what. But we're not there yet. But my gut impression is that this CVA is more of a neuronal disease.
Yeah, that's right. Well, there's a question about anticholinergics, either by the mouth or nasal anticholinergics in the past.
Yeah.
kind of discussion about that. What do you think?
So anticholinergics are an important and an interesting molecule because often respiratory physicians, we prescribe anticholinergics and we think of it mainly as a bronchodilator. But you've got to remember that anticholinergics are also, it inhibits the parasympathetic nervous system. So it will also improve or reduce mucus particularly. So that's why the glands are, mucus glands are new, they're mediated by the parasympathetic stimulation, cholinergic stimulation. So that's why I think that sometimes tiotropium and anticholinergics may improve coughing, not by their improvement in smooth muscle function, M3 muscarinic receptors, but by their action on the glands. And the third component is that I know Maria Belvisi, maybe about 5 or 6 years ago, they did a very nice guinea pig study showing that tiotropium, not only does it have impact or influence on smooth muscle, but it may also have off-target effects on airway nerves. It may have anti-neuronal properties. So that's why I think that tiotropium is an interesting molecule. I'm not sure whether that's the case for every anticholinergic, like aclidinium or olodaterol or any of these other new anticholinergics. But there is some scientific rationale for anticholinergics. And the other thing about the nose is important because a lot of people have runny nose out of season. And often it's vasomotor rhinitis. And they sometimes benefit from an anticholinergic type nasal spray. That's been my experience.
Yeah, that's very interesting. In the past, we did a small study, in fact, on athletes that had a cold air induced asthma. In Canada, we have a lot of this. It's interesting because half of the group were responding to anticholinergic while the other half had absolutely no benefit from it. So maybe there are peculiarities in regard to what you mentioned.
Yeah.
So there is another question about induced sputum. There are some questions about how the technique should be done, but I think it may lead to a more general question about the role of induced sputum in the investigation of chronic cough. Of course, I'm biased because I'm a proponent. I like very much this technique, but of course it's not available everywhere. So do you think it's a mandatory test, or should we develop it? What about that?
I think, personally, I think from a scientific perspective, if we were living in an ideal world, I think if it was me, I'd like to know what's happening inside my lungs. Treating something locally in the lungs, I need to know what I would like to know what's happening in the lung. The problem and the challenge that we have is that sputum eosinophil induction and processing is time consuming. It is expensive. It requires specific, techniques. You need somebody who does regular counting of slides to make sure that there's not too much error. So it's only done in specialist centers. But if you live in the developed world, I'd hope that there's centers within close proximity that you can refer somebody in for a sputum cytology to look for eosinophil. Now, if you're living in rural areas and you don't have access to this, some of my colleagues will say, if there is sputum eosinophilia, Imran, then the way you're going to treat it is prednisone and high-dose ICS. I said, yes. So they will say, well, I'm going to try this anyway. I will just try it. And if they respond, then I know there must be some sputum eosinophils. The problem with this thing is that it's a bit crude, and you may also miss neutrophilia. You may also, because prednisone makes lots of things better. It's not, you feel better with prednisone. Generally, if you take prednisone for 1 week, you'll feel better. So it can be a bit non-specific. So you might still not be left with a good diagnosis. But if the blood eosinophil is very high, 3, 4, 500, and if you have access to pheno and it's 50, 60, 70, then maybe you can say, I think maybe they probably have got cough variant asthma. Oh, sorry, eosinophilic bronchitis, and I'm going to start treating.
Yeah, interesting.
That's not a reasonable approach.
Yeah, no, indeed. Yeah, no, I think. Well, there is something related to glottic dysfunction and ILO, exercise-induced laryngeal obstruction and cough. And treatment of that, speech therapy, and so on. Do you think this is a very prevalent condition in chronic cough?
So when we ask patients about, tell me, where do you think the cough emanates from? In my practice, at least 70% say, oh, it comes from the throat. But for ILO, I always ask them that, do you feel as if you have strangulation, a feeling of strangulation? Do you feel as if you're acutely breathless? Because people with ILO, they feel breathless because of the closure. But I don't see a lot of people replaying, oh, I feel so breathless, I lose my voice, I can't breathe, I have choking sensation. These kind of symptoms make me think it could be ILO. But if they don't have this, then I'm not convinced it's ILO. And in the past, we did a lot of laryngoscopies and things. And in very few patients did we see this ILO. But I suspect if you go to ILO clinic, I bet all of them are coughing. Or say a lot of people have coughing. So it depends which clinic you go to. If you go to the cough clinic, maybe not everybody has ILO. But if you go to ILO clinic, maybe a lot of people have cough.
Indeed. Interesting. There is a question from Dr. Lorena Steinemann about, in fact, the role of non-specific or non-opioid treatments in patients who had asthma, but where the inflammation is well controlled and have a persistent cough. Is there a role for these? There are benzonatate or different types of non-opioid cough suppressing medication. Do you think there is a role for those?
So the first important message is what as you correctly the questioner asked is, as long as inflammation is well controlled, exacerbations are controlled, FEV1 is good, then you could consider a centrally acting neuromodulator. The problem is that the evidence for this is not strong for benzoate or all these codeine. And unfortunately, the most evidence that we have is for morphine and pregabalin. Not pregabalin, but gabapentin. The pregabalin study actually was negative. The pregabalin study, which was done by Peter Gibson, demonstrated that pregabalin works when you combine it with speech therapy. There's never been a study of pregabalin alone. It's always been pregabalin with or without speech therapy. And it suggested that it was better with speech therapy than by itself. It had no significant improvement. So that's what I do. I give people centrally acting neuromodulators, usually opioids, when everything else is controlled and everything else is managed. And some people get benefit. And I'm hoping that in the next 1 or 2 years, we will have peripheral antagonists like P2X3 antagonists, which we can then add in to treat the cough.
And there was a question about the regimen with morphine. Of course, this is a drug that can become addictive in the patient, so we have to be careful about that. So, what is your usual regimen?
So, Alex, so usually when I start patients, I give them 5 milligrams twice a day only. And I give it for 14-day trial, a prescription only for 14 days. And the reason why I do this is because when you look at the 99 paper of Alan Maurice, which is the placebo-controlled, those that respond to morphine responded within 3 days. So that's the first reason, that often the responders are very early responders. So I ring them after 14 days and I then say, did it work? Did it help? If it helped, then I go on. I normally give them 5 milligrams twice a day for 3 to 4 months and then review in clinic. If it didn't work and they said, I couldn't tolerate it, I got constipation, unsteady, then finished. But 2 weeks is the initial, my trial. And then after that, if they respond, continue. If they don't respond, then I try something else. Sometimes I also, at 4 months, I ask them, did you miss any doses? And when you missed the doses, did the cough come back? And if the patient says, I missed a dose one day and it was fine, I was controlled. So then I say, okay, let's come down to once a day.
Okay.
So patients will tell you, I missed it one day and it was okay. So I say, okay, let's come down to once a day. Let's get you down to the minimum dose.
Yeah.
And sometimes I even take them off a break in the summer or something if they're fine, if they have a winter cough mainly. I've never ever gone more than 10 milligrams twice a day.
Good. I have a question about the role of first generation antihistamine in chronic cough of unknown origin. whatever you're suspecting, I don't know, asthma that has not been diagnosed for every condition. Is there a role in the treatment of chronic cough for those agents?
So I must admit that, my allergy colleagues use this a lot more than I do, because as you rightly point out, there is some moderate certainty evidence suggests that first generation antihistamines are antineuronal and can actually reduce the histamine in the nose and airways, and which may be sensitizing the nerves, and therefore it might have an effect. In all honesty, I don't use it that much, often because patients get too drowsy sometimes. One thing which I have started using with some success, though, interestingly, is in patients with allergic asthma or rhinitis with reflux disease, confirmed, symptoms of reflux. When I give them a PPI twice a day, I also then give them rupatadine at night, Rupal. And the reason why is because Rupal or rupatadine is a anti-H2, but also antagonizes platelet activating factor, PAF. So I've had some success, although this is just my own anecdotal evidence, but there's some scientific rationale why I think sometimes maybe rupatadine or Rupal might be slightly beneficial in that population of patients. But this is just my experience, Louis-Philippe.
So in the patient that are referred to you for persistent cough, despite having asthma treated, do you sometimes find the presence of asthma COPD in some of those patients that has not been diagnosed? Or
I do sometimes, because some people have stopped smoking 10, 20 years ago, and they have airflow obstruction. Sometimes they got fixed airflow obstruction, and these are the types of patients I tend to give them the LAMA, the TOs, and that kind of. So that kind of patient population, I say, let's give you bronchodilators, LAMA, and see how you do, and see how you benefit. And if they have mucus particularly, then I might consider azithromycin. But yeah, so I do get some handful of patients with both asthma COPD.
So in regard to the chronic non-asthmatic eosinophilic bronchitis, this is a very probably underdiagnosed condition, because people sometimes don't measure airway inflammation and they treat with an ICS, and then it responds, the cough disappears most of the time. What is your experience with this condition? I know that in my clinic we had some of these patients sometimes who had very high eosinophilia.
Yeah.
And amazingly enough, some of those 4, 5, 10 years later, they develop full-blown asthma. So do you think this is a continuum? This is a specific condition?
I think this is an interesting issue, because my feeling is that if you leave eosinophilic inflammation uncontrolled, then eventually you will develop mucus and debris in the small airways, and then you will get airflow obstruction. And we don't want that. So even though technically, when somebody presents initially with eosinophilic bronchitis, the guideline would say just give ICS. You don't need to give bronchodilator, because it's eosinophils you're treating. They haven't got asthma. But my preference is to give ICS and LABA, because I'm worried about the long term. Okay, and we know that the presence of eosinophils chronically may cause bronchial hyperresponsiveness over a long time. So even though the guidelines may say, you just need to give steroids, don't give bronchodilator, I generally give both. That's the first issue. The second issue is that I look at the magnitude of the eosinophil. Is it 3%, 6%, 10%, 15%? If it's very high, then I'm more aggressive, and I'll give them maybe a short burst of prednisone weaning dose and give them a higher dose of ICS. And sometimes I give them, say, Symbicort, which has budesonide, sometimes cyclesonide, but I'm also having some good success with the new fluticasone furoate. And sometimes I'll say, take the Brio fluticasone furoate, or Relvar in Europe or other places, and then take PRN Symbicort on top throughout the day, if needed.
Interesting. So I guess, go ahead.
So that's why, because I think that the FF furoate is very potent. and then that will bring the eosinophils down a lot better than just budesonide.
Yeah. And maybe if they have a persistent eosinophilia, that can lead to airway remodeling that can then maybe over time due to the development of asthma, I guess. So yeah, so we have to control the inflammation in those patients. So they have to be diagnosed, of course.
Yes.
I think we just have a few minutes. So maybe a last question. It is about gender differences. You spoke about the fact that some women with non-atopic asthma had sometimes and cough that could be associated with chronic cough hypersensitivity. Do you think there is really a gender differences in regard to cough?
So numerous studies. This is very interesting because so many clinical trials, and when you look at specialist cough clinics, almost all the data shows that females are overrepresented by 2 to 1 in the clinics. That's what the data shows in clinical trials and specialist cough clinics. However, when you look at population data in Canada and other countries, at the general community level, males and females are actually very similar. But I think that the females have more severe cough and they're more impacted by the cough, and therefore they go seek medical attention and come to our clinics. Whereas the men may not have as much frequent or severe coughing. So that's one thing. The second thing is what's very clear is that the sex differences are not the same across the whole world. We see the sex difference male to female higher in Western countries, Europe, America, North America, England, and UK. But in Korea, Japan, and China, there's no sex difference. Point number 2. The third point is, which is very clear from numerous studies, is that when you do capsaicin or citric acid or mannitol cough challenges, females cough way more than men. That's numerous studies have shown this. So I do believe that the reason why we're seeing more women in clinic is the fact that they have a more sensitive cough reflex. But that might not be the case for Japanese and Chinese women or Korean.
And do you think it's hormonal or something else? We don't know.
So we've often been asked this question, that is it, because they come in the 50s and 60s, is it the lack of estrogen that causes this? And honestly, I don't know. I actually don't know. I don't know. And I don't think there's strong. I think there's one study from Slovakia showing differences in capsaicin cough responses in the menstrual cycle, but it's only one study.
So anyway, there is a lot of research to do on cough still, chronic cough. So we're finished. So thank you so much, Imran, for this absolutely superb overview of this topic of cough and asthma. I think it's been very instructive, so interesting. So once again, thank you everybody for attending, and thank you very much, Imran, for this.
My pleasure. Hope you all enjoyed it, and hopefully I'll see you soon face-to-face, Louis-Philippe.
Hopefully. Thank you so much. Bye-bye.